Good morning, everybody. I first like to thank the organizer for inviting me for the first time to see this beautiful country and nice people. And I'm sorry that you are too early here, and we have a couple of people, so we can share some information about the topic. Thank you for coming or attending. I have no disclosures regarding this topic. We know that mesenchymal pathology is a bit complicated in general, but still we have some organ-specific or site-specific peculiarities. Specifically in the head and neck, we have too many entities that are in general rare, and most of them are site-restricted, so we don't see them in other organs. So this means in general, pathologists are not exposed to them, and only those doing soft tissue and head and neck or head and neck intensively may be more familiar with them. My talk is going to just to give an overview of the recent WHO classification list. Then I will talk about selected topics with some entities restricted to the head and neck, some showing a striking predilection. More than 70% of cases are head and neck sited, and then we have other entities that are as well frequent in the head and neck. I'm not going to speak about lipomas or other ubiquitous mesenchymal neoplasms that are known to be all overrepresented at head and neck sites. This is the WHO classification. We know that now every book has a special chapter at the end summarizing all of the mesenchymal entities that are ubiquitous to different sites of that organ or organ system. And at the same time, we have site-specific or site-restricted entities that are usually kept in that organ section. For example, Biphenotypic sinonasal sarcoma is retained in the sinonasal section. However, many other entities are distributed throughout. One of the highlights in this new book is the inclusion of two entities for increasing recognition and familiarity among pathologists. One of them is a very old entity, that is Phosphaturic mesenchymal tumor, because it is overrepresented at head and neck sites, and many people are still not familiar with that, so inclusion in the list will alert people to that entity. And the other one is a relatively new characterized entity, which is GLI1 altered mesenchymal neoplasm. When we come to the point of site-restricted mesenchymal neoplasm of the head and neck that are not seen in other organs, we mostly are dealing with three entities. One of them also is an older entity, which is ectomesenchymal chondromyxoid tumor of the tongue, and sinonasal glomerulonephritis, and not very recently, but relatively recent, is sinonasal biphenotypic sarcoma. These are entities that indeed are almost exclusively seen in the head and neck. There are very few exceptions when we encounter extra sites with involvement or presentation of these tumors, specifically relevant entities that are overlapping with ectomesenchymal chondromyxoid tumor. But we don't see biphenotypic sinonasal sarcoma in any extra sinonasal site, and we don't see sinonasal type glomerulonephritis, for example, in soft tissue or in bone. Ectomesenchymal chondromyxoid tumor, it is always called of the tongue because this is really a tumor that is practically restricted to the tongue, already reported in the 90s, with now less than 1,000 cases reported in the literature. But of course, the entity is well characterized, so it is underreported. New cases are not going to be reported by most others. They affect young adults, but with a very wide age range. They present usually as painless nodule, sometimes present for several years. Very few cases may recur locally, if not completely excised, but no metastatic potential, so they are benign. And they have a very odd immunohistochemical profile. And indeed, this immunohistochemical profile is a highlight of most of the site-specific head and neck mesenchymal entities. There is no clear cut. This is smooth muscle, this is neurogenic, but you have always a little bit of everything. So these tumors are positive for GFAP, variable for cytokeratin, S100, but not SOX10. This is a point that I will repeatedly because it is a very relevant diagnostic feature of many entities. SMA is positive frequently. However, we don't have too many rhabdomyoblastic markers. However, desmin can be, of course, positive, but usually focal or limited. This is an example, as you see here, the overall view, very well circumscribed. Chondromyxoid tumors are covered by normal mucosa, and you see always this vague lobulation with slightly pink stained and pale stained chondromyxoid or myxoid areas, so it is a myoepithelial-like neoplasm. If you are looking in your older files, if you have had encountered the case that was mislabeled, is usually as pleomorphic adenoma. Of course, then you see here very monotonous cytology. Usually we have a Grenz zone at the superior or superficial part between the mucosa and the node, the lesion. And at high power, it is very variable, but the most common feature is this microcystic or sieve-like myxoid pattern of the cells in the stroma, very monotonous cytology, no atypia, and this pattern is also very hyalinizing, and indeed we started to see similar tumors with these features in extraglossal sites, as including the soft tissue, but it is very rare. This is an example of the immunophenotype, as you see here. GFAP is the most sensitive and diffusely positive marker, S100 as well. So it is a myoepithelial-like phenotype, but usually without SOX10, without too much P63 or calponin and so on, and keratin is usually variably positive as well. So this is a very irregular immune phenotype, and recently it has been shown that these tumors are almost all unified by this fusion, RREB1 and myocardia-related transcription factor B, or former called MLK2. So all of them have this fusion. Indeed, they are very single cases with different fusion, but these are likely different entities and not the same thing. So this is a high degree of phenotype-genotype correlation. However, we started to recognize when doing a lot of molecular testing that some tumors with this fusion may be seen indeed in extraglossal or extralingual sites. And recently we put together 5 cases in this series with Dr. Antonescu, and we reviewed previously reported cases. So among these 10 cases, you see that indeed 60% were head and neck as well, although extraglossal, but they are still in the head and neck. So most of them are parapharyngeal. They are larger compared to the tongue lesions. They are more cellular. Still, they are indolent without recurrence or metastases, and they overlap variably with their glossal cases and perineurioma-like neoplasm with some reactivity for some markers. And indeed, recently I have seen the various cases that I spotted morphologically as being RREB1 fusion neoplasm in the gluteal region. So it seems that they occur in the soft tissue very rarely, and they recapitulate indeed in general these lingual cases. These are examples from our paper. You see here more cellular pseudocystic hemorrhagic area. Some of them are microcystic. And again, you see the very overlap with the with the tongue cases with some chondromyxoid, myxohyaline alternating areas in these photos. So it is exactly the same entity defined by these 2 genes that involved in the fusion. Next topic I like to touch in brief is biphenotypic sinonasal sarcoma. This is a sarcoma defined already, indeed, 13 years ago by the group from the Mayo Clinic, and at that time called spindle cell sarcoma, low grade with myoneural phenotype. And you see this is again a disease of adult with a median age of 52 years. They usually occur as many of the sinonasal diseases at multiple sites. The skull base may be involved as well. And symptoms usually are in general in sinonasal tract, non-specific, polyposis like nasal obstruction, rarely bleeding, and so on. And important is here the recognition of the entity, because this is a locally infiltrating neoplasm that does not metastasize. So if completely excised, similar to glomangiopericytoma, they are cured. However, if not completely removed, then the recurrence rate is up to 40 to 50%. Very rare cases has been described that transform into high-grade rhabdomyosarcoma, but this is a very rare event. They are very monotonous spindle cell, as in the majority of gene fusion-associated neoplasm. They can be paucicellular or highly cellular or admixture of both. When very cellular, they look like MPNST or adult type, so-called fibrosarcoma or spindle cell sarcoma. And the hallmark of these lesions found in the majority, but not all cases, is the presence of a prominent invaginated hamartoma-like epithelial inclusion. So they look really like sinonasal inverted papilloma with cellular stroma, sometimes if less cellular. And their immunophenotype is again heterogeneous, S100 without SOX10, so they are not neurogenic, they are yet myoepithelial-like or just aberrant expression of S100. Desmin is positive in many cases, but very focal, SMA as well. PAX7 and MyoD1 can be positive. Nuclear beta-catenin is also described in them, and they have usually very low mitotic activity and no necrosis. So if you see a very high mitotic rate, a prominent necrosis, always think this is something different than biphenotypic sinonasal sarcoma. This is an example. You see the surface epithelium and the invaginated glands looks really like inverted papilloma, can be very cystic. The background is, in this case, relatively less cellular, so really can be easily mistaken for a reactive lesion or an inverted sinonasal papilloma with stromal reaction. You see here even much more paucicellular variants that looks really like hamartomatous polyp or sinonasal papilloma with inverted glands. So this is a more cellular and more classical pattern, and indeed this pattern was responsible for being very long mistaken for a low-grade MPNST, because this alternation of dark-stained cellular areas with paucicellular myxoid light-stained areas is a common feature of nerve sheath tumors, and this tumor has been earlier called low-grade malignant peripheral nerve sheath tumors or cellular schwannomas, etc. This is a more cellular example that looks like adult type fibrosarcoma. Again, still you have sometimes more alternation of the fascicles, and this can also be, of course, by the non-soft tissue oriented pathologist as a smooth muscle or leiomyosarcoma, but they don't have the light fibrillary eosinophilic cytoplasm of smooth muscle cells, nor do they have the cigar-shaped nuclei. They have pointed hyperchromatic fibroblastic or Schwannian cell-like nuclei. You see here S100 is positive, but it is not diffusely positive. SMA is positive. If you have a good oriented slide, usually they are alternating. The S100 positive area is myogenic marker negative, and the reverse is true. And you see here accumulation of nuclear beta-catenin is in many of these cells. The two differentials indeed here are either spindle cell melanoma and the rare example of classical schwannoma in the sinonasal tract. Melanoma is usually very pleomorphic, very high grade, and most important is SOX10 positive. S100 positive is usually either myoepithelial or melanoma or neurogenic, and the reverse is mostly translocation associated mesenchymal neoplasm. So it is a very valuable marker. Schwannoma, as you see here, it is diffusely S100 positive, has this bizarre looking ancient schwannoma-like cytology, and the S100 shows the fibrillary or neurofibrillary matrix in the background, so everything is stained positive, and this is an example of what we see in sinonasal schwannoma. It is really rare. I see one case every 2 or 3 years. Very misleading is this pattern of sinonasal solitary fibrous tumor that really can be extensively hamartomatous looking. I have seen several cases of this type. It looks like a polyp, as you see here, and we have extensive glands lined by ciliated epithelium. They can have a proliferation of the basal cells looking like a papilloma, and the spindle cell component in the background is a neoplastic one. You see STAT6 is diffusely positive, so sinonasal hamartoma-like spindle cell neoplasm can always be either biphenotypic sarcoma or SFT. We have to address or consider both possibilities. If you need molecular, all cases are mammal-3 fusion positive with PAX3, very rarely PAX5, similar to rhabdomyosarcoma. So molecular is very distinctive as well if you need it, but usually it is not necessary for diagnosis. This is a very recent entity that we described 2 years ago. which is an aggressive sarcoma showing a multiphenotypic immunophenotype, very heterogeneous morphology, and characterized by fusion of one of the FET genes, which is FUS or EWSR1, with this PAU2AF3, or initially called COLCA2 gene. This is an entity that we initially characterized in 5 cases from different centers collected, and indeed all our cases were sinonasal, and then later on, a collaborative international study was published as well, with many cases, including some extra sinonasal cases. And to date, there is around 20 cases published in the literature. Still, you see that indeed 2/3 of cases are head and neck, and half of them are sinonasal. So this is also an entity that is still very under-recognized, even not known by many or most pathologists, I would say. It affects middle-aged patients and older adults as well. The 5-year survival is about 50%, so it is an aggressive disease, and all of them have this fusion, some of them instead of the EWSR1 FUS. And I will show you example of this very challenging entity you see here. Mostly we have this biphasic pattern in most cases, which is an undifferentiated, nondescript spindle round cell sarcoma morphology in the background, interrupted by these dark stained, primitive looking, pseudo-cohesive basaloid cellular aggregates. This is the most frequent pattern, and they can be, of course, at P2 positive, as you see here. Myogenic is positive in some of the cases. And it has an epithelial and mesenchymal, neurogenic-like, rhabdomyoblastic-like phenotype. Another pattern seen in some cases is low-grade fibromyxoid sarcoma-like, as you see here. Very rarely we see bizarre-looking hyperchromatic nuclei. You see this case with metastasis here to the skull. So this is a very heterogeneous disease, but most cases really can be at least suspected when we see this primitive dark stained nodules in an undifferentiated sarcomatous background. This is the most challenging variant. This is the case indeed from Dr. Skalova from Pilsen in that series included as well. It looked like a basal cell adenocarcinoma or very basaloid epithelial looking neoplasm with very neural invasion. We have some palisading, some acantholytic pattern in the periphery, some clearing of the cytoplasm, and still it is the same entity. And of course, more challenging in this case that I have seen last year came with the diagnosis of high-grade non-intestinal type adenocarcinoma, and it looked really like a pseudocribriforming and glandular adenocarcinoma. However, if you look at low power even, there is something special, which is the biphasic pattern. We have more stroma in the background. The cellular nests are very distinct, and here it looks really like intestinal type or non-intestinal, if you like, adenocarcinoma. And indeed, this case exactly has the same fusion. Then I went back and looked exactly at the slides, and indeed, you see this pattern again here. This is small, primitive, cohesive basaloid cells in a sarcoma-like round cell, spindle cell background here seen as well. So my impression is that this sarcoma may be in one or other way analogous to synovial sarcoma. We know that as a very small subset of synovial sarcoma, they look like adenocarcinoma. They are 99% epithelial with gland formation, cytokeratin positive. Indeed, they look like upper GI tract adenocarcinoma. So this may be an analogous phenomenon that we can have too much epithelial differentiation, although still considering it mesenchymal in origin. Adamantinoma-like Ewing sarcoma is a rare type of mesenchymal neoplasm that combines the genotype of Ewing sarcoma and the immunophenotype of squamous epithelium. So it is an epithelial differentiated Ewing sarcoma variant with striking predilection to the head and neck, and in the head and neck, mostly in the salivary gland, in the major salivary gland, in the sinonasal tract as well. Welfare is described 1999. To date, less than 60 head and neck cases have been reported, or some of them are thyroid-based as well. And these tumors do exactly express the markers expected in Ewing sarcoma. However, in addition, neuroendocrine markers are frequently positive, and all squamous cell markers, P63, P40, CK5, 6, and so on. So it is a very challenging diagnosis, and it has much better outcome compared to classical Ewing sarcoma. The genotype is very variable. We have mostly AWSR1 Fly1 in the majority of cases, similar to Ewing sarcoma. However, ERK fusion seems less frequent compared to classical Ewing sarcoma, and in subset of cases, as in this published series, we have the FUS and FEV and many other fusion variants, similar also to Ewing sarcoma of soft tissue and bone. They can be very similar to basaloid squamous cell carcinoma, very similar to neuroendocrine carcinoma. When you diagnose high-grade neuroendocrine carcinoma or net grade 3 in the salivary gland, this is most likely to be Adamantinoma-like Ewing sarcoma, and the same applies to other sites. This is another entity, indeed, is described also during the last 1 decade, which is a high-grade sarcoma in the spectrum of epithelioid and spindle cell rhabdomyosarcoma, and this again has a high predilection for the head and neck, and mostly for the sinonasal tract, has very complicating diagnostic issues because of the immune phenotype and because of the morphology. Most cases affected the maxillofacial bones. Both sexes are involved equally, and the median age, as you see here, is very young, 29 years, so it is a disease of young adult and has a very high local recurrence rate and metastatic rate, and most patients will die of the disease. The problem with this entity is that on one side it looks very frequently pleomorphic, so I remember I missed definitely a couple of cases early as sarcomatoid squamous cell carcinomas because usually pleomorphism is not expected in fusion entities. And the second one is that it has much more keratin and ALK expression than myogenic markers. So desmin is frequently positive, can be diffuse, but myogenin and myod1 really are very limited, and sometimes even in the biopsies completely negative. Again, we see the fusion of FUS or EWSR to this TFCP2, and indeed, all these markers, though confusing maybe in general, are helpful to recognize. When I have an entity in the sinonasal tract or the maxillofacial bones expressing desmin, ALK, and pankeratin, you can really be sure this is that entity without molecular testing. So you see here, it does not look like a rhabdomyosarcoma in most cases, so it looks like a spindle cell sarcoma or very bizarre looking pleomorphic, as you see here. So sarcomatoid carcinoma is the most frequently misdiagnosed entity because they are pleomorphic spindle cell epithelial positive. So no one has a problem to call it spindle cell carcinoma. You see some rare cases like this in the series by Christina Antonescu with too much rhabdomyoblastic differentiation with strap cells or rhabdomyoblastic cells as well. And again, you see cytokeratin is diffusely positive, ALK is diffusely positive. So this is one of the considerations that we have to look at. Again, this is a review we published a few years ago. You see desmin is less than low molecular weight keratin and less than ALK. So, but the three markers are indeed very suggestive and almost pathognomonic for that entity if no technical issues were there. This is again an entity that we described recently, and it is evolving. There is also one abstract submitted to the USCAP currently, so it is going to be a defined entity in the future, but still is not well characterized, which is a neoplasm with VGLL3 fusion. And indeed, it has many peculiarities. One of them is that half of the cases were in the tongue. Again, adult in the middle age are affected mostly. And indeed, they are not really aggressive. And I remember as we submitted this paper to Genes, Chromosome, and Cancer, I used in the title low-grade myogenic neoplasm, and the reviewers insisted we have to call it spindle cell rhabdomyosarcoma. Then to let the paper be accepted, we use the term, but still I am not convinced, and I am sure we will revise the terminology to tumor or neoplasm and not rhabdomyosarcoma, because this is always joined with an aggressive course. If you tell any oncologist the patient has a rhabdomyosarcoma, then aggressive treatment is always the option. So this is a very unusual and rare entity. You see here again the table with the location mostly in the tongue, in the substance of the muscle, and you see two different fusion types, mostly TCF12 and EP300. And it is very striking that all later reported cases with EP300 VGL-L3 fusion were all in the tongue. There is no single case outside the tongue. So this is a very distinctive neoplasm, and all cases affected males, so we don't know why. And you see that none of the patients developed recurrence or metastasis. This is one of the whole mount section. You see here the muscle of the tongue, and you see this moderately cellular, very monotonous neoplasm invading into the skeletal muscle, sometimes looking like nodular fasciitis or myofibroblastic proliferation, really very bland looking, mostly no mitosis. A few inflammatory cells are seen in the background, and you see here in this other example, again, intramuscular proliferation of bland-looking spindle cells, high power showing exactly this ovoid, very monotonous cells, diffusely desmin positive, highlighting also skeletal muscle in the background. However, myogenin and myod1 are really very, very limited. This is one of the new kits on the block, Gli1 fusion neoplasm. And Gli1 amplified neoplasm is a family of mesenchymal neoplasm, indeed already reported in 2004 by the group of Dr. Fletcher and others, and then it took 14 years until this was characterized really as an entity by Dr. Antonescu and Dr. Agaram in 2018, and later on another group has been discovered to show not a fusion but amplification. I will show you example of that. So Gli1 is mostly fused to ACTB, less frequently to MALAT1 or PETCH1. So this is a hedgehog signaling pathway neoplasm, mostly low grade. The amplified cases were detected because they looked similar to the other cases, but they don't have a fusion, and indeed they have amplification of the Gli1 gene locus. To date, 28 cases have been described, but this is also one of the emerging entities that are under-recognized. I have definitely more than 10 unpublished cases in my files, although we recently put a very large series together with Dr. Antonescu. So this is also not that very rare, but it is definitely under-recognized. And this is also one of the easiest diagnoses. This is an example from the Dr. Antonescu's papers. This is a tongue nodule, which is the most frequent site in the head and neck. And indeed, at low power, when you see this extensive lobulation of dark stained cellular neoplasm, even at low power, your first diagnosis is a Gli1 altered neoplasm, either fusion or amplification. You don't see another entity in the tongue looking like this. And if you look here at this overview table, we see that indeed many of the cases were head and neck sited. However, if you compare those with a Gli1 translocation versus Gli1 amplification, there is a very striking site variation. For example, acral lesions are mostly fusion, amplification associated, very rarely fusion, and the same applies for head and neck. We have 26% of the amplified cases in the head and neck, but no more than 7% in the fusion arm. They are mostly epithelioid, monotonous with ovoid to spindle cells, very glomus cell-like, bland cytologically in many cases, more atypical in the amplified scenario. They have this prominent multinodular plexiform growth pattern. They are very well vascularized with scant stroma, and the immuno is very non-characteristic. However, still you can diagnose them by morphology and immunohistochemistry. And the differential is mostly glomus tumor, pseudoendocrine sarcoma, neuroendocrine tumor, and bicoma, of course. This is an example of the amplified tumors. You see extensive multinodularity, plexiform pattern, this sinusoidal vascular pattern. However, when you compare the amplified to the fused cases, you see some differences. The cells are larger and more atypical in the amplified tumors, and this also correlates with their more aggressive behavior compared to those with the fusion. Here you see microcystic spaces with mucoid secretion in the background, very monotonous cytology as well. If the case has a Gli1 amplification, then it is very easy to separate from the fusion cases because the amplification of Gli1 is very frequently associated with pan-amplification of chromosome 12q. We have in that region CDK4, STAT6, MDM2, DDIT3, and Gli1, of course, as well. So many of these are positive. So if CDK4 look like this and the morphology is Gli1 compatible, this is Gli1 amplified tumor. You don't need more than that. You see here STAT6 as well, and it usually shows not the strict nuclear pattern in SFT, but nucleocytoplasmic expression, which is a feature of amplification in many genes. CD10 and CD56 are universally positive, but both of them are not really specific and not helpful. If you look at the immuno for diagnosis, then we have, as said, CD10, CD56 positive in both types of tumors, however, non-specific. Now we have a GLI1 antibody that is also relatively specific and sensitive. And if it is positive, then you can add this chromosome 12q located antigen CDK4, STAT6, and MDM2. If one or two of them are positive, this is amplified. If they are all negative, this is usually fusion case, and you don't need really more than that. And you see in this example, this is a GLI1 fish. The photo is, in one case, I sent to Cristina Antonescu. But now, because there is no commercially available GLI1 fish probe, you can use the same fish probe that we use for myxoid liposarcoma, which is the DDIT3 split apart fish probe that can also detect copy number variation of GLI1. So this probe is used, but if you order it, you have to tell those looking at the fish, please look at copy number variation and not split apart signals, because it is usually used for translocation and not for amplification. These are two papers examining the specificity of the GLI1 antibody. The first one published from Brigham by David Babke, and this is our collaborative group. And you see that there is a very distinctive nuclear expression. So this is really a very good marker to recognize these tumors. This is an example that really is misleading. As you see here, from the epiglottic area, this mass looked very ulcerated, very cellular. High power shows very lymphoepithelial looking, or even FDC sarcoma-like with very large ovoid cells, a lot of sprinkling of lymphocytes. But you see that here keratin is negative, B53 is abnormal, and B16 is diffusely positive. CD21, CD23 are negative, so it is not a follicular dendritic cell sarcoma as one of the differentials. And indeed, CDK4 and STAT6 and variably MDM2 positive. And this is, again, one of these examples of GLI1 amplified epithelioid neoplasm or sarcomas with this diffuse B16. And if it has this lymphoepithelial pattern, of course, it can be definitely misleading. Focal MDM2 positivity should not mislead us to under-recognize follicular dendritic cell sarcoma, because they usually have a subpopulation with amplified MDM2. We published this a few years ago. Glomus tumor is one of the differential. This is an unusual example from the parotid gland, multinodular plexiform, very glomoid cell, so it can be really very easily mistaken for a GLI1 amplified or fusion entity. However, we have completely different immune profile. SMA is uniformly positive and collagen 4, so glomus is a completely different entity. Pseudoendocrine sarcoma is going to be included in the currently being composed WHO classification. This is a very monotonous neuroendocrine-like, mostly keratin-negative neoplasm, frequently with this psammomatous microcalcification, and it looks very glomoid or very GLI1-like. However, it has uniformly beta-catenin mutation and abnormal expression, and most cases are paraspinal. They are just close to the vertebral column in the head and neck. 1/4 of the cases, or 1/3 of them, are located in the head and neck, the others on the back, but mostly paraspinal location. And you see abnormal beta-catenin, variable CD34 and S100, again without SOX10. So this is an aggressive sarcoma with very frequent metastases to other organs and to the lymph nodes as well. This is the last point, just to touch in very brief, which is the F1 or fibronectin-1 fusion neoplasm. We know that phosphaturic mesenchymal tumor is the prototype of this. It's a disability tumor, unfortunately mostly diagnosed very late, and the patient may have been sitting in the rolling chair for 5 or 6 years until diagnosis is made, because it is usually indolent, very small nodule. And as you see here, very rare among soft tissue tumors, but still we have 50% distributed between soft tissue and head and neck and bone. So the head and neck has no less than 20% of all cases. And most patients present with osteomalacia or bone pain, multiple bone fractures. So clinical information is very important. If you know the clinical information, diagnosis is before looking into the microscope, very possible. If you don't know that, it can be very misleading, specifically in the head and neck, because the morphology is usually variant and not the classical morphology. You see here, 80% in the hard tissue, 20% in the soft tissue of the head and neck, so not really rare in the head and neck. And paranasal sinus is the most common extraoral site, and male and female are relatively similarly involved with the mean age of 46. And this is a disease that can recur locally and metastasize in a very small proportion of cases. This is the easiest case in the soft tissue mostly, and bone with this grungy or dirty granular matrix in the background. This is not very difficult for soft tissue pathologists to recognize. However, head and neck cases are frequently variant. They may look like glomerulonephritis, very cellular in the sinonasal tract. They may look like chondroid neoplasm or spindle cell sarcoma or hemangiopericytoma, as you see here, or even very similar to central giant cell granuloma with these giant cell nodules in the background of hemorrhagic and fibromyxoid stroma. So in the head and neck, they are very frequently very misleading in morphology. This is a case came with a diagnosis or suggestion of neuroendocrine-like epithelioid hemangioendothelioma because it was ERG positive and podoplanine as well. But as you see here, ERG is very weak, which is the typical pattern in phosphaturic mesenchymal neoplasm. And this tumor indeed has focally, if one looks exactly and is aware of the entity, this bluish bone as we see in aneurysmal bone cyst. So this is a hallmark of this entity when you see that this is a phosphaturic mesenchymal tumor. They have a non-specific but jointly helpful immunoprofile. SAT-B2 is uniformly positive in all cases, CD56 as well, and they have a distinctive ERG that is very weak between normal cells and negative. And this is similar to what we see also in cartilage. When you stain cartilage, it looks also very weakly ERG positive. Somatostatin receptor 2A is also positive in the majority of cases. This is the last point with the same gene fusion, not exactly the same, but FN1. And this is a recently described calcifying chondromyxoid mesenchymal neoplasm, first described 2021, again by Chris Fletcher and the group. And here it is important to see that in the original description, half of the cases were acral, half of them involves the temporomandibular joint. So they are specifically head and neck in that area. This is one of the very helpful information. They mostly look like chondrosarcoma of the skull base on imaging. They can be locally invasive or chondromatosis-like of the temporomandibular joint. Their behavior is indolent. They don't metastasize, but they can recur locally. And of course, they have a very distinctive lacy or grungy calcification, very granular bluish calcification. If you have seen one case, you recognize them always very easily. You don't need even immune or molecular. But most of them, they have FN1, FGFR3 fusion. And you see here one of the examples that we have seen in our department recently, very large skull-based and sinonasal associated nodule, and you see here this very bluish granular matrix formation with very, very low cellularity. This is one of the very distinctive pattern of this entity that can be recognized and distinguished from others. They usually have not been described to be associated with osteogenic or oncogenic osteomalacia. So, to summarize, we have seen that mesenchymal head and neck neoplasm represent a special group of entities. They are rare to very rare, and most of them have defining molecular features, but fortunately, mostly we don't need the molecular testing for diagnosis. Most are low-grade to intermediate. Very rarely they are aggressive, like TFCP2 fusion, rhabdomyosarcoma. Most have an odd immune phenotype that on one side can be misleading, on the other side can be abused to suspect diagnosis or spot them. And many have no counterpart in other body sites like Biphenotypic sarcoma and glomerulonephritis and so on. And so the familiarity with them is the only key for diagnosis. So if you are doing soft tissue and head and neck, it is easier for you. Otherwise, head and neck should be communicating with soft tissue, and the reverse, of course, is true. And the clinical and demographic features are very important for diagnosis, and they will help to limit the differential diagnostic list. And very important is that they have frequent keratin expression, which is a pitfall. We have seen this in Adamantinoma-like Ewing sarcoma, but as well in TFCB2 fusion-associated rhabdomyosarcoma. Thank you very much.